Assalamu alaikum everyone. Today I have one more topic to study. So we start as a case. This is case 1 and this is case 2. So case 1 is 30-year-old male patient. He is road driller, use electric vibrator drill for activity. He is complaining of discomfort in the right hand. There is numbness along the right hand, more along the thumb and the index finger. The second case is 25 years old, female, 5 months pregnant, complaints of numbness along the hand and more over the thumb and the pointing finger, and more in the night and gets up in the sleep due to shock-like sensation. So what we need to ask if such patients comes to you, the duration, how it started, any history of trauma or injury, or any other systemic disease. Systemic disease means possibility of diabetes mellitus or sorry, diabetes mellitus, hyper or chronic kidney disease, rheumatoid arthritis or chronic kidney disease or any other autoimmune disorder. And we need to check for any local swelling, any how is the thenar muscle activity and the sensory distribution of the median nerve in the hand. So, before starting what exactly the carpal tunnel syndrome is, we need to know little about the anatomy of the carpal tunnel. So carpal tunnel is an osteophaseous tunnel. The floor is formed by the carpal bone. Roof is formed by the carpal transverse carpal ligament. So this is the floor. Scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, and hamate. These are the carpal bones. So on the lateral side, the transverse carpal ligament attached to the scaphoid and trapezium. On the medial side, it is attached to the hamate and pisiform. So it's extending from here like this. It is extending from here like this. This is transverse carpal ligament. So as I told, on the lateral side, it is scaphoid and trapezium. On the medial side is pisiform and hamate. So what are the contents of carpal tunnel? Carpal tunnel contains 9 tendons. There are 4 flexor digitorum superficialis tendon, 4 flexor digitorum profundus tendon, and 1 is flexor pollicis longus tendon. And it has one nerve in it, that is your median nerve. If you see here, this is transverse carpal ligament. This is transverse. This is the median nerve inside. And this is the cut section where you see 1, 2, 3, 4 flexor digitorum superficialis, 1, 2, 3, 4 flexor digitorum profundus. This superficialis and profundus, they have single synovial covering. And where is the separate tendon here, that is flexor pollicis longus. And this yellow one here marked as a median nerve. So these all are content of carpal tunnel. 8 flexor for the fingers, 1 flexor for the thumb, and 1 nerve. So 9 tendons and 1 nerve is the content of carpal tunnel. So here is the um, um, median nerve supply. Median nerve. If you see median nerve, it has sensory supply and the motor supply. Motor supply is supplies to the thenar muscles, sensory to the thumb, pointing finger, middle finger, and the radial aspect of the ring finger. So 1, 2, 3, 3.5, and the lateral aspect of the hand. This is sensory supply. Motor supplies, thenar muscles are supplied by the median nerve. So what are the causes of carpal tunnel? So this was once asked in your PG exam. What is the common cause? Idiopathic cause is the common cause. Sorry. Idiopathic etiology is the common cause. Okay, then we have physiological causes where there is no need of intervention, just counseling and just conservative treatment will do. Obesity, pregnancy, and the menopause. We have local causes. Local causes is ganglion arising from the carpal joints, compound Walmar ganglion, then local benign or malignant tumors in and around the nerve sheath, malunited radius fracture. Among them, the Colles fracture, not the Smith fracture, it's a Colles fracture. Colles fracture. Colles fracture. It was also again asked as a PG bit in past. Then lunate and other carpal dislocation also compromise the carpal tunnel and cause compression over the median nerve. What are the systemic causes? Systemic causes are hypothyroidism, diabetes, acromegaly, chronic renal failure, heart failure, and mucopolysaccharides, and so on. So what is pathophysiology here? So what is happening is there is increase in the pressure in the carpal tunnel. So this increased pressure causes compression or tamponade effect over the median nerve. So every nerve has vasa nervosum surrounding them. So when compression happens, there is alteration in the intraneural blood supply. This compression of the compromise in the blood supply to the nerve causes symptomatic presentation of compression. So what is the clinical presentation? Patient will have numbness along the median nerve. As I told, it is thumb, pointing finger, middle finger, and the lateral aspect of the ring finger. And this pain is more in the sleep, because in the sleep, wrist unintentionally go into flexion. Flexion causes increase in the compression over the nerve and increase in the intracarpal pressure. Then poor grip. The grip is poor because there is a wasting of the thenar muscles, as median nerve supplies the thenar muscles also. So there are two specific phenomena related to nerves. One is called as Wellick's phenomenon, other is called as Tinel sign. So what is Tinel sign? What is Wellick's phenomenon? Wellick's phenomenon is when we compress over the nerve by tapping over the nerve, the pain will radiate proximally. That is, if you tap at the wrist, the pain will go radiate proximally. It's called as Willis phenomenon. Same way, if you tap on the nerve, the pain will go, and there is radiation of pain distally. So Willis phenomenon proximal, Tinel sign, the pain will go distally. So how will you diagnose? So as a presentation, anyhow, we know clinical symptoms, the specific sign for the carpal tunnel. This is called as Phalen's test. What is Phalen's test? We are flexing the wrist to 90 degree, opposing both wrists together. Okay, so here if you see, this is the normal side, if this is the abnormal side, due to the increase in the carpal pressure, there is kinking of the nerve and alteration or tamponade effect over the vasa nervosum. So this is how we elicit the Phalen's test. Other is Tinel sign. You tap along the course of the nerve. When you tap, the pain radiates, or the electric shock like sensation will radiate towards the nerve supply, cutaneous nerve supply of the median nerve. There is one test called as Durkan's test. What Durkan's test is, if you apply continuous pressure over the nerve in the carpal region for 30 seconds, 30 seconds, the patient start feeling paresthesias. If you apply for 30 seconds, here for Phalen's test, we keep it for 1 minute. So how will you diagnose? Diagnosis, most of the clinical diagnosis by all these tests. We do X-ray if we are suspecting malunited radius fracture or any carpal dislocation or anything. We do ultrasound or MRI if we feel like there is any soft tissue. And if you see ultrasound, there is diameter of the nerve changes, because due to the continuous compression, the nerve diameter will change. And if there is any soft tissue lesion, we'll see on X-ray or ultrasound or MRI. Then how was the confirm the diagnosis? We have electro diagnostic tests. So we do nerve conduction study, we do electromyogram. Nerve conduction study is very diagnostic, and we do very commonly. We stimulate the nerve proximal to the carpal tunnel, and we see how the signal are getting travel to the distal aspect. So we stimulate here, we catch the signal here. So if there is a compression here, the flow of signals will slow down. So the conduction velocity of the nerves decrease. So specifically in case of carpal tunnel syndrome, conduction velocity of the median nerve decreases. So this is how you diagnose carpal tunnel by doing nerve conduction study. Then once you have diagnosed, how will you treat carpal tunnel? So we have non-operative methods of treatment, which is we can give NSAID, we can give extension splint, because just now we have seen flexion of the wrist causes increase in the carpal tunnel pressure and causes compression over the nerve. So if you give extension splint, this will decrease the pressure in the carpal tunnel and will activity modification. If patient is exposed to the vibration or patient's activity need lot of flexion at the wrist joint, we will ask him to change the activity. If patient still having pain, then we can give intralesional steroid. As I told, either methylprednisolone or we can give triamcinolone. Not in the nerve, in the perineural region, that is in the carpal tunnel. So here, if you can see, this is how we give injection in the carpal tunnel. Sometimes from distally, sometimes we can give it proximally also. Then, if patient is still having the symptoms, when we do carpal tunnel release. What is carpal tunnel release? Will open the fascia, that is transverse carpal ligament, will cut it open so that there is no any roof. It's otherwise de-roofing of the carpal tunnel. So we can use endoscope and we can release it endoscopically. We can do open release by giving a big incision like this. So uh, how just you remember there is something called as Kaplan's line. What this Kaplan's line is? It is a surface marking of the safe zone for the incision of the median nerve. So here this is otherwise called as carpal lines. So just you remember there is something called as carpal line, Kaplan lines. This Kaplan line is important when you are doing open release of the carpal tunnel to avoid direct injury to the median nerve. So, and if patient is having diabetes, if patient is having acromegaly, if patient is having hypothyroidism or other any systemic disorder, we need to manage the systemic management by giving medications pertaining to the disease. And if patient is having pregnancy, you are not supposed to do surgery, or because it's self-limiting. Once after the delivery, over the period of time, the fluid in the body goes off. So till then, you can just give extension spleen to the patient and proper counseling.